Ladies and gentlemen, it is an honor for us to be here today. We will be presenting on a condition that is most clinically challenging and impactful for patients. We invite you to explore with us strabismus, diagnosis, and the most recent approaches to treatment. So, first of all, we're going to begin with the definition of strabismus. As L'Anthony defined, it is an oculomotor syndrome with two components. So the two components are the motor component and the sensory component. The first one is the motor component, which occurs when the deviated eye assumes an abnormal position relative to the fixating eye. As the first picture shows, the different type of muscles that are responsible for the eye movement. However, the second picture shows an orthophoric person and a different type of strabismus: esotropia, exotropia, hypertropia, and hypotropia. The second component is called the sensory component, which disturbs the binocular vision leading due to a misalignment leading to confusion or diplopia. So the question here is, what is confusion and what is diplopia? Confusion occurs when the macula receive two different images from two different points. However, diplopia occurs when the retinal images of points do not align on a corresponding retinal points, leading to have two different points. However, diplopia persists in adults. Nevertheless, it is neutralized through two adaptation in children, with the negative adaptation and the positive adaptation. So the main question here, what is the negative adaptation and what is the positive adaptation? The negative adaptation is called suppression, where the brain ignores the deviated eye image. In addition, the positive adaptation is called the ARC, which is the abnormal retinal correspondence, where the brain tries to have adapted a normal binocular vision by changing the different references of the macula of the deviated eye, aligning it with the non-deviated eye, so we have a binocular union. So normally, we're gonna pass to the normal retinal correspondence to know what is the abnormal retinal correspondence. The normal retinal correspondence is when both foveas share the same direction, the same visual direction. However, it's not the case in the abnormal retinal correspondence. Also, we have two different types of the abnormal retinal correspondence, which is called the ARCH, the harmonious, which attempts to restore binocular vision at the strabismus angle. And here we have a more extended scotoma to neutralize the angle zone, and it can lead to amblyopia. The second one is the disharmonious ARCD, where the alignment between the eyes fluctuates with a varying neutralization zones. Now we're going to start talking about the first type of strabismus, which is called the normal sensorial strabismus. So what is the normal sensorial strabismus? Is late onset esotropia, non-accommodative, appears between the age of 2, with a hypermetropia is minimal, and the real etiology of this case is not well defined. Passing to the clinical presentation. This case of strabismus appears suddenly between the age of 3 and 4, and it is also triggered by many factors such as illnesses and psychological stress. However, this condition may start intermittently before becoming constant. To know more and deeply about this type of strabismus, the normal sensorial strabismus, we're going to talk about the type of a normal sensorial strabismus, which is called the circadian strabismus. As the picture shows here, a girl with a normal binocular vision for 24 hours, and the other day with esotropia and absence of normal binocular vision. So this is called the circadian rhythm, where It's a cyclic with 24 hours and may extend to 48 to 75 hours. Yes. Now we're going to pass to the treatment of this type of strabismus. First of all, we're going to begin with the optical correction. We need to prescribe the full hyperopic correction. In the second hand, the prismatic correction, prism or press-on, depends on the case. So it should be applied for maintaining fusion and stereoscopic vision, and it can delay a surgery intervention. The surgery in this case is necessary to restore fusion and binocular vision, and the technique depends on the recession of the two rectus muscles. However, aesthetic and sensory prognosis are good in this surgery, but it is necessary to be performed quickly, especially in young children with fragile binocular vision once the angle is stabilized. Another solution, which is called the botulinum toxin, with 45% of satisfactory results with 1 or 2 injections. And here are some uses of the botulinum toxin. Here the before and after, as you see in the picture. Now we're going to pass to a case study to make a summary of all of this case and understand more. So here we have a child with 5 years old with no history of systemic illnesses or neurological condition or previous ocular surgery, and no one known in the family history of strabismus. The chief complaints of this child is that their parents complained from that his child has a normal binocular vision in the first 24 hours. However, the absence of the normal binocular vision and esotropia the second day. So after doing all the assessments, we have the results. Refraction plus 1.5 OD, OS plus 175 with a full range of motion in both eyes. However, the cover test reveals in the morning 8 a.m., day 1, no deviation at distance, neither near. In the afternoon, the second day, intermittent esotropia, 8 prismatic diopter at near. And the third day, no deviation at distance. And the fourth day, the esotropia with 18 prismatic diopter at near and distance worsens with fatigue. So, before giving a diagnosis of this type, we need to put hypotheses. The hypotheses here are maybe is due to an accommodative excess, maybe due to a weakness in the muscles, and maybe more hypotheses. So we did the NPC, which is the near point of convergence, worsens throughout the day with 6 centimeter in the morning and 15 centimeter in the evening. However, the accommodation and decreased amplitude and response later in the day. And also the stereoscopic is good in the beginning of the day, however, it worsens at the end of the day. So the management plan of this child is the first step, we need to put glasses, the full hyperopic glasses, and exercises to maintain accommodative strain, and we need a break and rest strategies, they are a must for this child. The follow-up, a re-evaluation in months to monitor progression and restore treatment. However, if all of the symptoms furthermore worsens, we need to do a check-up with the neurologist to check the myasthenia or any other disorders. And the real recommendation for this case, for you, our optometrist, is to never ever give a final diagnosis and decision in the first consultation. And now it's my main turn, Dr. Douaa, Kerbaa. Thank you all for listening.
Thank you, Doctor. Hello again. So now we will pass to talk about the second type of strabismus that we did mention it with you. In this type of strabismus, we're going to start by definition. As we see, the early onset strabismus is defined as a constant misalignment of the eye that being before 6 months, around typically 3 months, non-congenital and non-accommodative. Please, big line about this. And it envelops distinct oculomotor and sensory sign. Now we pass to talking about pathophysiological. The real cause of this type of strabismus is really not distinct yet, and it's now unknown, but neurophysiological studies have been provided inside that at birth, fusion and binocular connection are immature in the first 6 months. So any disruption to this process may result from a brain abnormality affecting fusion that could lead in strabismus, a sensory defect such as a congenital cataract, a motor dysfunction leaving the visual system in a mature state. So let's focus about this note here, that this factor can prevent normal binocular vision development, keeping the visual system in archaic mood. To more understand this type of strabismus, we're going to begin with the etiologies. That is a perinatal neurological impairment when the cortical lesion caused by cerebral hemorrhages being the first factor risk for this type. Prematurity and low birth weight. As we know, the infants born before 33 weeks and weighing around 1.5 kilograms are really considered about this type. Heredity and ophthalmological abnormalities, as we did mention it, cataract congenital. Now we pass to talking about the clinical science and going deeply about this type. We have these 3 big factors or signs that we could from them understand this type. We have strabismus and their types that we will mention it with you. Torticollis, which is the abnormal heat posture that, as we know, child adopted when they have early esotropia to improve visual and increase the nystagmus. We have nystagmus. We present with you this diagram, and we have the immature visual system before the age 6 months, and this really severe factor who could disrupt it and give us this clinical science. The absence of development of retinal correspondence that could lead by very poor binocular vision and stereoscopy. Absence of development of sensorimeter fusion that's also leading and controlled version with 80% of esotropia, 10 exotropia, and 10 microtropia. Persistent temporally to nasal bias in attraction toward addiction and latent manifest nystagmus. Presence of primitive reflex such as DVD, which is dissociated vertical deviation. Now we pass to talking about the type of strabismus to more understand. We start by the horizontal deviation, as we did mention it in the left slide, that we have 80% of esotropia, 10 of exotropia, and 10 of microtropia. For the 80% of esotropia, it's defined with a very large angle, more than 40 diopter. As we see here, we have this child here with early onset strabism, esotropia, with a very large angle, as we see. And as we see, their eyes fix at different fields with alteration. When we have alteration between eyes, now we can be in somehow in the good position, as there is no risk of amblyopia. But when we have really one dominant eye, now we could present the amblyopia risk. For this type of strabismus, we really advise to start surgery before 2 years. We have exotropia with a 10% that may result only from neurological problem, and we need to do evaluation, neurological and pediatric. We have microtropia, and we cannot never know about it only by amblyopia presence. So we pass now to talking about vertical deviation in this type, and which is 2 types, DVD and elevation addiction. We start by dissociation vertical deviation, which is hypertropia in early onset strabismus. Occurs with the asymmetric visual stimulation, often detected under unilateral occluder. As we see here, this girl, under the occluder, it's like causes slow deviation and exclusion that may disappear when remove the occluder. It's really, really hard to detect it, and it's very, very early to appear. When we're talking about the elevation in addiction, it's different from DVD, but as it doesn't appear with the occlusion. It's increased addiction and decreased abduction. Now we pass to talking about treatment of early onset strabismus. We start by medical treatment, which is optical and orthopsy. We have optical correction and amblyopia management. We start by optical correction. As we did mention it, it's non-accommodative, but it's really, really important to start by optical correction as a first step and not neglected to avoid any another factor severe. We give the full-time corrective glasses, and we do like each time repeat cycloplegical exams to correct any risk of hypertropia. Amblyopia management, which is the second important step here, the real purpose is to equalize the acuity between the eyes. We start by eye exercises, and when really the child doesn't give us the real good results, and the dominant eye still develop, we go to occlusion therapy. We need to work with ophthalmological and neurological in this type of strabismus, and we need like a checkup every month. For surgical treatment, okay. For this type, really, we start by botulinum toxin injection to relax such specific muscles as the medial rectus. We started by it to have a good result. In either case, we go into surgical treatment, which is for objective, as we know, aesthetic and functional improvements as purpose to have a microtropia. Any surgical have a factor to consider, as we know, size of deviation and type of deviation, presence of torticollis. For size of deviation, more the deviation is large, more we have to start early about surgical. Type of deviation, more we have one more of deviation, we start to correct the most is large. Presence of torticollis, we need really to start surgery before to have another body problem for the child. Now we're going to talk about age and timing for starting surgical or botulinum toxin. About surgery, like typically we advise before 3 months, around 18 months as good results. For botulinum toxin, we doing 1 to 2 injection before also 3 years. That can achieve for us a microtropia in 40 to 60% of cases. Now I present with you this child case with 8-month male, full-time of birth with no complication. Their parents report that this child starts to have a deviation typically around 3 months when their right eye starting inwards. So we start our examination, and we found that both eyes can fix it and follow the movement targets, but fixation prevalence slightly favored the left eye. So now we start suggesting there is a risk of amblyopia. We start by Hirschberg test when we find that the right eye show us a nasal reflex deviation around 30 prism diopter of esotropia. To confirm this result, we use a cover test as it's very, very good motor test in distance and near, and we found a constant large angular esotropia between also 30 and 40 prism diopter. We start in adding lens to know if this type is accommodative or no, but like you see, relative deviation. We pass now to starting thinking about the neurological health. We're doing a stereoscope PTNO. Can you please zoom back? And we found absence of forced performance looking test, that compromise the binocular region. We do encycloplegical refraction, and we found both eye plus 2.5, with the visual acuity in the right eye 0.8 and left eye 0.1. As we see, we have functional amblyopia. So let's summarize what we have. We have now accommodative esotropia with a very large angle, with like 18 months. So that makes us really thinking that this type is the early onset strabismus esotropia for infant. So we start a management plan, as we know, by amblyopia therapy, as we give them the full-time wear of hyperopic glasses, and start patching the better eye seeing, which is the OS, from 5 to 10 minutes daily. We asked mom to do it. And we started thinking about surgical correction, as we know. So, pass it. The follow-up, we asked their parents to have it every 6 months to check visual acuity, and we advised them to do a surgery around 18 months. So our recommendation for this case, or for in general early onset strabismus, is that the early detection and intervention always give us good results and prevent from amblyopia. Thank you.
Thank you.
Thank you.
Thank you so much.
If you have any